Thank you. Thank you, Dr. Singh, for that amazing talk. So we're going to go ahead and get started with the moderated session here. If the audience has any questions, if they could stand in line by Ryan, our coordinator, right there, and stand in line, and he'll pass on the mic in the queue so that you guys can ask the questions that you need to ask. We have a first question already. Okay.
I made you walk like 3 times yesterday already, so. First off, thank you for the fantastic talk. My question is, and I think Dr. Liu, you alluded to this, is that the patient plays a huge role in this as well, right? And a lot of why the costs are so high, and coming from somebody who do a lot of patient population analysis, we see, I see that the prevalence of some stuff, of some conditions in the US is just so much higher compared to Europe, etc., because the patients are so sick, right? And so I'm curious, how big of the chunk of the slice of the pie are related to addressing patient behavior before they reach the healthcare system? And is AI, and are you specifically looking at tools that can impact that portion of the patient journey?
Yeah, that's a great question. I mean, obviously not everything. I think healthcare is one aspect of this, and health is another aspect. And they're overlapping, but they're not the same. So there needs to be a larger societal shift around kind of the achievement of health. And that will have a lot of beneficial downstream impacts on the cost of healthcare delivery. But as I showed in the slide, there's, I think, a big role that health systems do need to play if they're organized around value, which is providing wellness and kind of the resources for patients to be engaged and the opportunities for them to really improve their health and prevent these downstream consequences. Some of that is things like screening rates, other things of that is education. We do have pilots in that. I myself am a user of a AI tool that we're going to be rolling out to 2,000 of our patients, where I lost like 25 pounds in 3 months by simply using this app and some wearables. So, I mean, I think it is important for a health system also to provide those as opportunities to bend this cost curve.
Hi, I have a question for Dr. Singh. So as I was watching, discussing about moving patients from Friday to Monday, the way I kind of saw that is like, what if my boss came to me and said, we're not really using computers too much over the weekend, so I have a great idea, you need to work over the weekend. We probably wouldn't take it very well. And you kind of mentioned it briefly with capacity, but capacity is, people not being able to see their kids, having to get childcare over the weekend, or have a constantly rotating schedule. And I guess where do these sort of the human factors of, caring about the healthcare workers and not just room usage and equipment usage, where does that come into play?
Yeah, it's a big part of it. I think the reason that we looked at Monday to Friday was especially because we assumed that, having surgeons come in on the weekend and having that be a regular thing, and not just surgeons, but all the staff, would just not be a tenable option to start with. So I think that, honestly, the clinician well-being, a lot of the clinical tools I didn't talk about are actually the ones that are really helping in that space. AI scribing technology with kind of the ability to do a lot of downstream tasks that you normally would have had to do manually, that's kind of initiated at the point of contact with the patient. AI that we use to draft replies back to patients that help clinicians get their replies out faster with less cognitive burden, where we've looked at what are the things that clinicians actually spend their time editing to try to fix those based on prompts. So I would say if you look at clinical AI today, I think when I said clinical AI, 5 years ago, you'd be thinking predictive AI, and you'd be thinking, oh, it's creating additional work through alert fatigue. Nowadays, when we think about clinical AI and generative AI in clinical care, almost invariably every solution is pitching a better clinical well-being as one of the things that they do. So I didn't talk about it here mainly because I think in the operations side, I'm looking at it from the patient perspective. If my patient has to get their surgery delayed 2 weeks because we don't have a bed to actually land them after they do their surgery, what does that mean for them? Obviously, you have to consider what does it mean for a system, and even just casually saying we can move 20% of our cases, people have clinic, people have lives, people have other commitments. So I think that you need that kind of thinking to be able to understand what's even possible. Because if someone came to me and said, oh, you could create like 10 more beds, I could tell them, no, you could never create 10 more beds with that strategy. That wouldn't work. So that actually helps us make sure that the things that we're doing are backed by data, which right now I would say most health systems don't have the luxury to do that.
Hi, I actually have a question also about the the kind of imbalance of admission and also operations happen in hospital. When I saw it, my first reaction is, oh, that's just doctors want to take weekends, and then I see the hospital registration also has that pattern. Then it hits me like. It's exactly like we have a work schedule, and patients and doctors have work schedule. We have weekends. And it's almost look to me like, okay, Friday is leading to weekend. Saturday, enjoy your life, and Sunday, oh, all of a sudden, okay, tomorrow I'm gonna work. So if I wanna be sick, I'm gonna be sick today, and so I do need to go to work on Mondays. I kind of feel like maybe another fix of this problem is outside of healthcare, which is have a flexible work schedule for everybody, so you can decide when to go to the hospital or relax. So that's a comment, not a question. So I want to shift to another question, which goes to both of you, because a common theme of both your talk are talking about dealing with reports. Notes to reports, and to maybe extract information for further research or for further utilization. And it's all have a component that you should get as much original notes as possible, even combine them from different sources. And and then later on you talk about the cost. And I actually throughout this several sessions, during poster sessions, I met only one gentleman talking about, okay, there's a project using LIM, and this costs a lot of money in this. So I'm really wondering, like when we were talking about the cost, there's money cost, there's the resource cost, the energy cost. I want to understand, for both your experience, like what's in your cases, like what's the real cost, adding together money-wise, resource-wise. I know, eventually if we save lives, it'll worth it, but I do really want to hear more about, the real costs behind AI. What are they? Yeah.
I'll share a quick response to that, answer your comment, and then I'll turn it over to Vinny. So I think one of the reasons we are using LLMs outside of the EHR is we can choose which LLM to use. And I think that, training is expensive, inference is cheap. Training is very environmentally destructive. Inference, as there was a recent Anthropic paper that showed, is not nearly as destructive as when you compare the use of AI against a whole host of other things that we do, you can kind of actually map the resource use of AI in terms of its effect on environment and cost. So I'd point you to that Anthropic paper. But just to say that one of the reasons we chose the approach that we did was informed by the fact that inference is cheap. So it's really not expensive to build a 2-layer neural network as it would be to train a large language model from scratch. So for us, training a large language model from scratch was out of the question. And even for the other tasks, Llama 4 to me is a great example of a model that is very cheap per token and has a very long token window. And so it's not the best model for many things, but it's a model where it strikes a good balance when it comes to cost and just capability, because it saves you from having to do retrieval augmented generation for tasks where it's really an information extraction task. It's reasonably okay. The first comment you made, I'm actually going to flip it for you and actually give you a sense of what the reality is. If I told you there's 2 hospitals, one in which the doctors are available at 2 in the morning to do a CT scan at bedside in the ICU, which I've seen, for a patient who's about to go on ECMO, which is a extracorporeal, like outside way of basically replacing their heart and lung function all at once. And there's another hospital that is closed on weekends, that basically nothing happens over the weekend. Which hospital do you think is busier? It's not the second one, it's actually the first one. So it's not actually that like doctors don't want to work that leads to busyness, it's health systems that are the most well-equipped and highest resource that can actually save your life is where everyone wants to go. And I think the challenge is how do you direct people away from those hospitals when they don't need those hospitals? And that's actually where a lot of the issues come from. Certainly well-being is important, but I think if we we improve the work hours at that busier hospital, things would only get dramatically worse, not better, from an operation standpoint.
Yeah, I mean, I think I'll just tie into that point. I think for most doctors, at least who are working in the hospital setting, are working on weekends already. So I don't think that's a new cadence for most. But I think there's a little bit like of a moral injury when you can't do a surgery that you believe a patient needs in a timely fashion, right? And so there is a kind of a negotiation and a balance that could be achieved where, providers feel empowered to do the thing that they think is right, and patients are able to get it, and the system is load balanced appropriately. As to costs, I would say the approach of having many LLM options in the armamentarium is right, because I don't think we've seen those costs stabilize yet. We've seen them come down, but we don't know what the future is with increasing number of models, ones that are open weight, open source, and so I think being flexible and not adhering to this is the only model we will ever use is probably not a very sustainable path. But the cost of AI is very much in flux, and we've seen that very dynamically, probably even examples of that over this last week. And so I think, I think that's still yet to be seen, and how we think about contracts and negotiating costs. I would say that's very unsettled because of the pace at which innovation is occurring.
Hi, good morning. Thank you both for your presentations about kind of the implementation of AI and how we do this in a thoughtful manner throughout the system. My question goes back to the patient experience part of this. Kind of given the moment that we're in right now, where AI is becoming an increasing part of all of healthcare operations, how do you think about the ways in which we bring along those patients who don't trust these tools, or who are like all of our parents who barely understand their iPhones, let alone these AI tools that we're integrating in care, especially when it's not necessarily realistic for physicians to understand, the nitty-gritty of all of the tools that are being implemented, let alone, even just the AI basics.
I mean, I think there's a fallacy that older folks are not necessarily using AI. My mom was recently diagnosed with myasthenia gravis, and she keeps texting me from ChatGPT, like all the outputs and how she believes it. So, I mean, I think there's other factors besides age that are at play here. But I really, truly believe with the pace of innovation that patients do need to be brought along. The tools should be dual purpose. They should be available to clinicians, and those outputs should be made available in a consumable way to patients as well. It's the only way that we're going to engender trust, and it's the only way, because generative AI does make errors, right? And if everybody understands we're working with this this tool that is essentially trying to bring us insights, but there's cases where we need to correct it for sure. And I think the only way that's going to happen, not in an adversarial way, is for us to have patients engaged in that. And I think a lot of the mistrust of AI has to do with sometimes it's placed in like cybersecurity, like is my data secure, or is it flowing to a company where they're going to be using it to profit off of it? And so allaying some of those fears or being very clear about those is one. And then I think second, there's the concern that it's disintermediating the interaction between a patient and a physician, let's say, that human touch. And I actually think no matter, I mean, the goal for, I think, most people in healthcare is that we actually strengthen that human bond, no matter how many layers of technology we put in between, but that we're actually bringing and making that interaction more meaningful. So, I mean, I think we're at a stage at which, you know, all of these tech leaders, and we're seeing it today, that the capabilities of these tools are outpacing, becoming on par or even outpacing what we can do as humans. It would be a disservice to ourselves and our patients not to take advantage of those, but do it in an aligned way.
Yeah, I think part of the trust issues stem from the fact that a lot of our AI to date has been clinician-facing, but for the patient. We're seeing more direct-to-patient AI, and so I think the people who really do want to use it will have the ability to use it, whereas when it's the clinician, the patient's not really often empowered to be in a decision to decide, or position to decide whether the clinician uses it or not. So I think the things that you can do is you can make sure there's disclosure when there's direct-to-patient, or where it's a patient communication, or there's documentation that a patient's going to read that the patient knows. Some patients won't like the disclosure. They say, I don't want to know if it's AI generated or not, or, you know, but I think that we view it as a kind of an important thing to do. There's a great editorial last week from Michelle Mello at Stanford that talks through, I think, some of the considerations around when to disclose and when maybe you shouldn't disclose, or when you don't need to disclose. And for us, the other thing is, in certain cases, consent. So there's still cases where things are new, where it makes sense to just consent someone, to let them know and give them the option to opt out, when it's really okay for them to opt out, which for more direct-to-patient stuff, it often is okay to let them opt out, in the same way that you can escalate a phone call to a human. And then we have our Chief Patient Experience Officer sitting on our Health AI Committee. So our AI governance includes direct input from the patient voice through our Chief Experience Officer.
Hello, good morning. Thank you both for the wonderful talks. My name is London Lowenstone. I'm currently a PhD student at the University of Minnesota, studying how AI systems react to populations that are non-standard or outliers. And there are kind of two ways that this often happens: is either people don't give responses, and so you don't have data to train on, or they give responses that are very different from all of the other groups that you've had responses from. And so I'm curious, I know you mentioned how once you know one healthcare system, you know one healthcare system, and also that equity is a very important part of healthcare. So how have you dealt with being able to provide equity for these populations or healthcare systems, however you collect data for the groups that either don't have as much data to provide, and also provide different data than these other groups that you may be training your models on?
Before you answer that, I actually want to just jump in on that. You know how you just said one healthcare system, you only know one healthcare system, but even within the healthcare system, like each hospital is like very different. Like when you're a resident or fellow and you rotate through three different hospitals, like the local hospital, and the hospital where like transplants and ECMO happens, and then like the VA or something, very different patient populations. So excluding the VA for now, like between the community hospital and then like the more private hospital, you know, there's definitely differences. So how do you balance all that, and how do you know you're, you know, doing it right?
What I'll share is that, starting at a structural level, our Chief Equity Officer sits on our AI committee. So that was a kind of a key commitment to make sure that the leads who are actually responsible for thinking about health system equity are actually there. So we don't think about AI equity, we think about equity for the system. And so I think that some of that follows from the way a model performs in a subgroup. Some of that follows from the way in which that model gets used to drive a decision and what resources we throw around it. And so I think that it's the answer is we look at it holistically. We are a lot less metrics driven than I think one might expect, mainly because the metrics often don't give you the answer you need in terms of what to do next. I mean, there's kind of those outlier cases, I would say, or cases like from, Ziad Obermeyer, where fixing the algorithm actually fixed the problem. But most of the time, it's some mix of the algorithm and what we do. And one of the things that generative AI has changed is that it used to be the case that everything was a predictive model trained at your system, which has existing inequity. Now it is LLMs trained across the entire internet, including, Reddit and who knows what, that are guiding clinical care for our systems. So I think that it's just a whole different world we live in. And so we've tried to introduce mechanisms, even in our node casting approach, to try to handle and purposely withhold information from the models that we don't want them to consider as one way to try to make sure they give us consistent performance where it matters, where we think that it's going to weight something that it really shouldn't be weighting.
Yeah, I think that's right. I mean, this is a really important issue, but it's a vexing one, because when you, even if you metricize the measurement of like variable performance by subgroup, there's always going to be a subjective decision in there about what the delta in performance, you know, is that meaningful or not? But I would say this, I think you can take an unfair algorithm and deploy it in a fair way. That's my hypothesis. You can definitely take a fair algorithm and deploy it in an unfair way. So I think that overlap between what arises potentially from an algorithm and then how the system is designed around how that's used and ultimately measured, right? Because the proof will be in the pudding. If the gap between one group and the other diverges, doesn't close, or closes, I think that's going to be essential because we can't de-bias everything through math. Like it's just not, it's not possible. And then there's the human part about the choices made around that.
And just real quick, one actual example of that actually happening is at Case Metro Health. Yasir Tarabichian team had deployed a no-show model, a much maligned no-show model, and shown that deploying it in the right way actually improved no-show rates for minorities disproportionately better than it did for other folks. And so it almost like directly addressed inequity if deployed in the right way. That's not always true, but that was an actual real-world case where I thought that was interesting to see.
What do you mean by the right way? What sorts of things are you shifting?
So no-show model, what do you do with it? Do you double book patients? Or do you call people and offer rides to people who have a transportation problem because they're high risk not to show up? Yeah.
Wonderful. Thank you both for your responses.
Hi. I'm actually a postdoc at the VA, so kind of curious. I had two questions. One is around, so this is a lot about the technical and operations and like sort of high level. I'm wondering, there wasn't a lot of talk in terms of like advocacy and how AI can maybe drive that interface between at the higher like government and systems level. Just like areas to focus on in terms of like that area of like legal advocacy and such. So I'm sort of curious about your perspectives on that and where ML research can play a role. And also curious your perspectives in terms of more sustaining the AI system. Like as a researcher, like fundamentally the things I research are impacted by what I've experienced in my life. And especially with AI, it can be the case that the people who come into this with that technology expertise or whatever can be like, from different populations. Do you see a role in terms of like, like mentorship, some sort of programs for like 10 years down the line, making sure that like all of these different health inequities, like that different people experience, like those people have that AI expertise?
I guess maybe I'll start with the second one, which is that in our experience about deploying use cases of AI, end users who know their domain super well are essential, right? Like even if it's like an ambient AI scribe, the ultimate kind of rubber meets the road of how it's used in an oncologist's office versus a psychiatrist versus an outpatient primary care doc are very, very different. And it might be the same underlying technology, but their experience of using it could be vastly different. And I use that as an example to say we need people in the AI development ecosystem at all levels from many, many different backgrounds. Because I think that they together represent many different perspectives, shared and lived experiences. And if we are to guide this and keep this technology aligned with our ultimate human values, then it needs to be representative of the diversity of those types of values. So that would be, I think that was the question you were asking. And how do we do that and achieve that? I mean, that's a challenge, but I mean, I think with the pace of change, again, AI is racing ahead. Yesterday we heard Dr. Mahmood say, the pace of computation has exceeded our ability to benchmark. Like, we are in a difficult place because it's a rocket ship right now. And so how to make sure we have everybody on board is really, really going to be challenging over these next couple years.
Yeah, I'll second that. That I think it is really important to, I think, mentor people. But that's why I said, working with people who have lived experience in the system, whether it's as a patient, whether it's on the other side, they'll often understand issues really well in a way that other folks can't, or that you need a diversity of folks like that. Your first point was on advocacy, so I'll kind of just address that. I think not a week goes by these days that I don't email either our state government relations or our federal government relations at the University of California, because there is so much policy change happening, which we need to weigh in on at the state and federal level. And so I would say any opportunity for public comment, we have put in public comments. We responded to the White House AI Action Plan public comment. We just responded to the one from NIH asking for ideas for their action plan. And we highlight some of the key priorities for us and say, like, as a system, we need to be able to study these things. And if the funding for AHRQ goes away, where does that sit? How does that work happen? Can the NIH be a home for that kind of work? So I think it's important for us as a community, as a research community, as a health system community, to make sure that when those opportunities come up, that we speak up. And they're necessary but not sufficient, right? Like if those emails go to the dustbin or go to the garbage, like who knows whether those are even getting read, because nothing is happening in a really transparent way. So I think we've just been making sure that whether it's through private channels with congressmen, whether it's through public channels, through public comment, that we're engaging and helping people understand the realities of healthcare and that what it means to see substantial federal cuts to research or substantial federal cuts to healthcare in terms of our ability to innovate in that space.
One last question.
Thank you so much. My name is Jorge Rios. I'm a postdoctoral research fellow at Mayo. And my question is I think healthcare is impacted by many social and cultural phenomena constantly, right? So I was wondering what measures you take to keep updated your models, your systems, and what are the biggest challenges that you have encountered towards that problem, and also what are your recommendations or tricks to handle that? Thank you so much.
I'll share one thought on that, which is actually in one of our public comments. So the public comment, one of the points that we made is that right now, because of Office of Civil Rights and other laws, you cannot use machine translation anywhere where accuracy is essential. And what that effectively means is that if a patient doesn't speak English and sends you a secure chat message that's asynchronous, that if they send that to you in English, you can easily respond. If they send you in another language other than English, most systems are not equipped to handle that. So some systems have the ability to route that to a translator internally. Many systems, probably most, don't. And so what patients do is they actually run Google Translate on their side, convert it to English, send you the message. This is my hypothesis. I don't have proof for this, but I'm almost certain this is what happens. You respond to them in English because they wrote to you in English, and then they translate it back to whatever language they do. So I think that this is a one space where AI actually has a lot of capability for short, accurate messages when, defining what does it mean that accuracy is essential. The current status quo sucks. So I think that we can probably deliver more culturally relevant care if we relax some of the restrictions which were put in place for very good reasons to allow us to do more kind of culturally sensitive, which often translates to language first kind of things where we don't have the workforce. It doesn't exist for us to do individualized translation for every communication. I wish it existed, but I don't think it does.
Yeah, that's the same thing. Good example. That's a reverse discrimination. It was intended to reduce the discrimination in the health system, having ineffective communication, but by limiting the opportunity to use these tools, which are not perfect but quite good, to be able to communicate effectively, we're actually giving a lower level of care, unfortunately, to these patients because most health systems are simply unequipped to do that. I think those are, we have to, again, be really thoughtful about how we're deploying AI. Governance is really important, including different stakeholders who are looking at this issue from different angles to try to deploy it in the safest way and then to monitor those outcomes.
All right, well, thank you, Dr. Singh, Dr. Liu.
Thank you.